Great. Thanks so much, Keith and Tom, and to all the speakers for this wonderful invitation. It's always a pleasure for me to come back and speak with our friends and colleagues at FEN and kind of share our thoughts together. So maybe what I'll do is I'll share my screen. Let me see if I can make this happen. Be able to see my screen. And I'm going to bring up my slideshow. Are you seeing my slides as a presenter view, or Keith?
Yeah, no, we're not. We're still we're not. But I mean, if you expand it, that's better.
Can you see is it my slides or the presenter view?
Your slides.
My slides. Okay, great.
Okay.
So again, thank you for this great opportunity, and I'm happy just to sort of set the stage and sort of think about this as an investigator, as someone who writes clinical trials and tries to improve upon the care for prostate cancer patients. And so I work at Mass General Hospital. These are my disclosures. I'll just note that the MGH prostate cancer team is one that includes medical oncologists, urologists, radiation oncologists, pathologists, and radiologists. We do research because we're an academic medical center. We're trying to improve upon the care for prostate cancer patients. And this research is funded by a number of different institutions, all aligned at the bottom there, including the Prostate Cancer Foundation. But none of this is possible if it's not for the bravery of our patients who help participate in these studies. So a salute out to all the patients who are on the line today and who've participated in these trials. What I'll describe is something that I think we all know, that the problem here is that there's increased prostate cancer incidence or rates of diagnosis and mortality in men who are Black or African American. And for the sake of simplicity, I'm just going to describe this as Black men for the rest of my talk. So here we can see that from these data that the rate of diagnosis in Black patients is 60% higher than that of white men. These data come from the SEER database. The SEER is the NCI Surveillance, Epidemiology, and End Results Program. You can go to their website and you can create these same graphs on your own. And you can see here that there was a drop off in 2020 because there was probably just less screening during the beginning of the pandemic. But nonetheless, the trends still hold true. There's 60% more diagnoses of prostate cancer in Black men. What's worse is that this is the death rate from prostate cancer for Black patients as compared to white patients in the US. And the cancer-specific death rate is double that of white American patients. And this ratio used to be higher. It used to be around 2.5 or so. But nonetheless, it is still double. And this is, even though the ratio may be a little bit better, this is still unacceptable. So when I think about then, what's happened in prostate cancer, well, we know that the prostate cancer care landscape has really changed dramatically in the last 2 decades. So it's actually unthinkable to think that these death rates and this ratio remains the way it is, even in 2023. When I look back at 2004, this is the paradigm or the model that I use to think about the prostate cancer patient's journey, where he's diagnosed, maybe has surgery or radiation, and then if there's recurrence of cancer, these are the sorts of steps to get more and more advanced prostate cancer. And at some point in 2004, docetaxel or chemotherapy was the only treatment that we had. Fast forward to 2023, and we now have this host of treatments that have been FDA approved because they can help men live longer. And with all of this, the fact that the prostate cancer death rate among Black patients is still double that of white Americans is again, unacceptable. So how do we then think about, where are we going wrong, or what can we do? What can we do better? That's where we think then about the nature of this particular topic today, okay, which is that of clinical trials. So the reason to think about improved participation in clinical trials is that we don't know whether these drugs work equally well in Black patients. And so there are missed opportunities. So what do we know is that that the Black population in the US as of the census in 2020 was about 12%. But if you look at patients in cancer therapy trials, Black participants are about 4 to 6%. This, in fact, may be an underestimate because under 33% of cancer trials actually report race or ethnicity. And that's in all cancer therapy trials. What I want to emphasize here is that clinical trials, the way that I think about clinical trials, and the way I know that Keith and I have talked about this, Dr. Crawford and I have talked about this, is that clinical trials are a part of cancer care. So we shouldn't be thinking this as last-ditch efforts, but they should be offered throughout the arc of a cancer patient's journey, because at different times in that cancer journey, there may be clinical trials that may be appropriate for the patient at any particular state in their of their disease. So it's really important for us to think about clinical trials as a part of cancer care. So then the question might be, well, how inclusive have the phase 3 prostate cancer trials been? Those trials that led to FDA approvals that I've shown you here. Well, as I mentioned before, a lot of trials don't actually describe, they don't really report race or ethnicity. And this is me just looking through all of the trials that had publicly available data, and many of them didn't report race or ethnicity. And those that do don't perform very well at all. So here you can see the described percentages of Black patients in these particular trials. Out of any, the one that was highest were the original 2004 docetaxel chemotherapy studies. But here you can see that just like the other, the overall rate of Black patients' participations in cancer clinical trials being some 4 to 6%, you can see that those percentages pretty well hold true. So we've got some work to do. But why is this a missed opportunity? It's a missed opportunity because inclusive participation really matters. What we want to understand is are there differences in the effectiveness of these different drugs for Black patients as compared with other patients? And that same would be true for our Hispanic patients or Latino patients, and for our Asian patients and Native Americans and Pacific Islanders as well. So we need to understand that if there's a difference in effectiveness and safety. I think we need to increase inclusion so that we can really mitigate or eliminate racial and ethnic disparities in cancer care and to promote equity and justice. And I guess the other question for us really is it possible that Black patients might actually respond better than white patients? Well, I'll show you some of the data. There are 4 examples that I'm going to bring to mind here. The first example is of sipuleucel T. So sipuleucel T, the trade name is Provenge. It's referred to as a vaccine therapy that's made from a patient's own white blood cells. And it's also referred to as an autologous cell immunotherapy for metastatic castration-resistant prostate cancer, the very advanced state of the disease. Sipuleucel T, there were some prior studies that suggested that Black patients may derive a greater benefit as compared with white patients, but these are small numbers of patients. So what this study did is it looked at a registry of patients called the PROCEED registry, and they tried to match patients, white patients and Black patients, for their PSA level and generally other disease characteristics to try to understand, is it possible that Black patients, or how comparable is the response to sipuleucel T for Black patients as compared with white patients? And here's what they saw. The dashed curve here represents the Black patients who actually had a better survival. This is a graph of overall survival. So the further out to the right you get in this graph, the better you're doing. The Black patients actually had a better survival compared to the white patients, with a median survival improvement of nearly 10 months, from 25.8 months to 35.3 months. Here you can see the statistics. This is considered statistically significant. And so here's one example where participation in getting an experimental therapy could have benefited more Black patients, but they really weren't that involved in the initial clinical trials. Again, this is a registry after the drug was FDA approved. So, but what we can see here is that some patients may benefit more than others. Here's example number 2. This is a drug called abiraterone. The trade name is Zytiga. It is an oral hormonal therapy, also FDA approved. In this case, this is a retrospective study at Duke. And at Duke, they looked at patients, again, with metastatic castration-resistant prostate cancer treated between 2008 and 2015. They identified 45 Black patients and case matched them with 90 white patients just to try to understand how comparable are the responses. Here they looked at PSA decline, how much of a response in PSA was there with the abiraterone, as well as the overall survival. What they learned was that the results suggested that there may be a higher PSA response rate in the Black patients. That's including trying to reach an overall decline of 50% of the PSA. And even though survival was no different, even though the Black patients didn't clearly live longer, it's important to understand that the Black patients' response to abiraterone was not worse. So it's not that they didn't do better, but they didn't do any worse. So that's also important because it tells us something about effectiveness. Here are the graphs that really describe what are called waterfall plots. This is the decline or the best response in terms of PSA for the patients who are on the study. You start off at 0%, that's the baseline. And if you have a decline in PSA, you'll see that the bar goes below the 0% range. And here you can see this is the 50% line. And so for patients who had more than 50% decline in the PSA, you can see this bracket of patients, the Black patients, it was a greater proportion of patients than compared to with the percentage of patients who had a 50% decline in the white patients who were on the study. So again, describing that Black patients seem to have perhaps a better PSA response, and even though they did no better in terms of overall survival or didn't necessarily live longer, it's pretty clear that they didn't do any worse. Example number 3 is radium-223. This is also called Xofigo. It's called a radioligand therapy. It's intravenous radiation. I tried to pull together these different examples of different types of therapies just so we can understand that this isn't just limited to one specific example of these FDA-approved prostate cancer therapies. This is a retrospective study from the VA. They looked at 318 patients who had received radium-223, and 87 of them were Black. At the time of starting radium, the Black patients actually had a younger age, a higher PSA, and a larger proportion of them had received prior docetaxel chemotherapy. And why does that matter? It matters because these are indicators of potentially worse or more aggressive disease, having a higher PSA, having metastatic disease at a younger age, and already having needed docetaxel chemotherapy. And so what did they learn here? They learned that when they looked at the primary outcome of survival, if you look at this graph, the Black patients were described in red here, that there really was no difference in terms of the overall survival. You might see that the red curve is a little bit shoved over to the right, which might indicate a slight improvement in overall survival. But statistically, as this p-value tells us, there was no statistical difference in terms of overall survival. But if you look at the multivariate analysis, which takes into account a lot of the other disease features, not just how long the patients lived, but a lot of the other disease features, what they learned is that the patients who were Black actually had a 25% decreased risk of mortality compared to the patients who were white. So even though they had more advanced disease entering into the study, they actually had a decreased risk of mortality, suggesting that they had a greater benefit to the radium-223 as compared to the white patients. So another nice example of potential for improvement. And if only we could get such patients onto the clinical trials that led to these FDA approvals, this is earlier access to these very important drugs, and sometimes Black patients may respond even better. The last example that I'll give you is about enzalutamide. This is a randomized study looking at enzalutamide. It's another oral hormonal therapy that's used for patients with metastatic disease. In this case, it was used in the early form of the metastatic disease, also called hormone-sensitive prostate cancer. So men who were very recently diagnosed with metastatic cancer and started on their androgen deprivation therapy. And this study came from the Midwest, largely out of Detroit. So Wayne State, University of Michigan, and Ohio State. And this is a prospective study. And in this study, they've required 30% of the participants should be Black. So that's why this is also a very important study in my view. The outcome here was a 7-month PSA response. And here's what they saw. Of the 71 patients that they evaluated, 29 or 41% of them were Black. So they achieved their goal of actually enrolling more Black patients. What they learned for looking at everyone is that enzalutamide was better than bicalutamide. Maybe not such a major shock to any of us who treat this disease and have been using these drugs for quite a long time. But they saw that the 7-month PSA response, meaning the decline in PSA at 7 months, was very similar in Black patients as compared with white patients. So again, no better perhaps, but also no worse. And here is the graph for this that looks at the time to PSA progression. And you can essentially see that these curves of the Black patients and the non-Black patients essentially are not statistically different. This is the p-value, which also confirms that this is not statistically different. Why does this one really matter to me? The key takeaway for me is that this proves that enriching for Black patients in trials can be done, but it has to start from the very beginning. And you have to start with the idea that we must have a certain percentage of patients who are of a certain race or ethnicity, if that's important for understanding the relative efficacy of a drug. So what do we have to do? We have to stop missing these opportunities. Okay, we've had these clinical trials, as I've demonstrated to you, they've had a small number of Black patients. As you've seen, Black patients can do as well, or to flip it around a little bit, just to say that they at least do no worse. And in some cases, appear to do better than the white patients on these clinical trials in these retrospective analyses, case control studies, and small prospective studies. Now, you might say there are lots of limits to that. You're absolutely right. But these are hints that Black patients do the same or better. So we should be offering clinical trials as an opportunity to have early access to a therapy that could be beneficial. And again, I'll reiterate, it's important to understand that clinical trials are indeed a part of cancer care. So then I have to think about, well, where can we improve? And if we think about a clinical trial, there are a number of different key players in these trials, not least of which is the patients. That's a number one, but you can see that there are, other important players here, including investigators, including our colleagues from pharma. And I'm thrilled to have some of them speaking today as well, FDA and regulators. And then there are the folks who help us, help patients get into trials, like navigators and advocates and outreach groups. So there are probable paths for improvement. And what I'm going to focus on then is the potential for improvement among investigators, because I think the rest of us can talk, the rest of the speakers will sort of address some of the other areas. So for investigators, where are our opportunities to improve? And I think that this is not a complete list, I would say. I'm going to buzz through this and sort of describe a little bit more about this later. But if there's potential for education, so we can minimize bias of investigators with patients, we should be addressing diversity in our own workforce. We should insist upon diversity and inclusion for patients on trial, much like that enzalutamide study that I just described to you. We should be insisting on translated documents for other languages to be culturally sensitive. This is not just for Black patients, but for any patient who's underserved or underrepresented. We should simplify the documents and improve the information that we're giving to patients. So much of what we're doing has become ever longer documents that become very confusing for patients. You should be thinking about trial locations and other institutional barriers and address the barriers to participation. And the one that I'm going to focus in on a little bit is we should be thinking about our eligibility criteria and what exactly are we doing? I'm going to give you one example of addressing eligibility criteria. I'm going to go a little bit off the rails here, so bear with me. But I'll just describe that many clinical trials require an absolute neutrophil count of more than 1,500 cells per microliter. Now, neutrophils are a type of white blood cell to help us fight off bacterial infections. And it's a very easy to measure value here that's found in all of our blood tests for complete blood counts. So we'll always get a differential, and we'll look at the absolute neutrophil count. Anyone who's been on chemotherapy will have heard us say that you need to have a certain neutrophil count to be safely treated with chemotherapy. There is an entity called benign ethnic neutropenia that describes having an absolute neutrophil count, or ANC, less than 1,500 without any increased risk of infection. It's commonly seen in people who are of African and Middle Eastern descent. And this is associated with what's called the Duffy null phenotype. So this is going way off from prostate cancer. But this is the absence of expression of the Duffy protein on red blood cells. Why does this even exist? Well, this phenotype of red blood cells, and for these people, has a selective advantage against malaria. So you can see why this has persisted in large populations who are perhaps subject to malaria. And there's a selective advantage for why this continues to exist. Well, benign ethnic neutropenia, or this absolute neutrophil count, is something that can lead to consequences. So in a Boston-based primary care center, a team led by Lauren Mers, the publication's down at the bottom. Dr. Mers is a fellow in our hematology oncology program, but during her residency, she evaluated healthy Black patients. So these are not patients who are sick. They don't have cancer. They looked at patients and tried to identify their white blood cell count and whether or not they have this Duffy null phenotype. What do they find? 2/3 of the Black patients, the people identified as Black, self-identified as Black, had the Duffy null phenotype, a full 2/3, 80 of 120. Their absolute neutrophil count was lower, more than 2,000 cells lower, 2,820 compared with 5,005, compared with the other Black patients who were Duffy non-null, who had so-called normal. 24% of those Duffy null patients had an ANC less than 2,000, 10% had an ANC of less than 1,500. As I wrote at the top here, many trials require an ANC greater than 1,500. But as I'm showing here, 10% of the patients who were Duffy null had an ANC less than 1,500. So you're talking about a lot of patients who may be excluded from clinical trials for a benign process. So this can have consequences, as I mentioned. So sometimes patients who have a low neutrophil count get referred for a bone marrow biopsy to understand why is their ANC so low. And there was a study that was published in 2021 that showed that 97% of Black patients in this one study who were sent for a bone marrow biopsy only because of their low neutrophil count, they were Duffy null, and almost all of them had a normal biopsy. They had a procedure that's invasive that they could have avoided, but they had an invasive procedure that comes with risk. Such patients may also have reduced doses or discontinuation of effective medications, such as azathioprine that's used for rheumatologic conditions, simply because a lack of understanding of that their low ANC is actually normal. And as I mentioned, these sorts of patients may be excluded from clinical trials for really a benign condition. So what can we do? We can stop using this term benign ethnic neutropenia. We can call it, Duffy null associated neutrophil count. It's a normal variant. We should be thinking about Duffy null specific ANC ranges. So, if we just say these are race specific ranges, that wouldn't actually suffice, because there were patients who identified as Black that did not have this Duffy null phenotype, and they had neutrophil counts that were in what we consider the current normal reference range. So we shouldn't be excluding patients who have this low neutrophil count. What I've learned is that the test is pretty simple. And the test only costs about $32.45 per sample to look at Duffy and 3 other protein groups. So it shouldn't be thought of as a difficult test to do. So we should be doing more for these patients, not less. So here are the investigators' opportunities. We should educate. We should educate our entire staff so we understand what are the issues at hand. When we increase diversity, we increase the points of view in our workforce that can improve care. When we insist upon diversity and inclusion in trial design, that can improve upon the care for patients. When we have better translated documents and work with sponsors and advocates, we can include more patients in culturally sensitive manners. When we simplify the documentation, we can reduce the bloat of all the paperwork that can frankly scare patients off. We should be thinking about clinical trial locations and institutional barriers. We should be looking outside our own walls. And then we should be thinking about other barriers to participation, like transportation, parking, and childcare, all of these things that we should be thinking about and trying to figure out how can we work on this. And then we should reevaluate our eligibility criteria. I just gave you one example about the Duffy null. So let's recenter this paradigm. Let's not think about clinical trials necessarily, but let's put the patient at the center. And rather than thinking about, do I have patients for my trial? We should be thinking of, do I have trials for my patient? And so when we think about all of this in a patient-centric manner, well, what do we need? We need patient advocacy, just like Fenn's been doing with it for information for patients, and not just for what is prostate cancer, but information such as fentrials.com that describes, what are the trials? What do they all mean? We as investigators need to demonstrate our own commitment to diversity, equity, and inclusions, everything I just mentioned in the previous slide. And in doing so, we should then be working towards ways for us to promote outreach, such as my colleagues, Dr. Kwok Trin at Brigham and Women's Urology, and Dr. Adam Feldman from Mass General Urology created the Prostate Cancer Outreach Clinic to try to improve the care for patients in Boston with prostate cancer in outreach. What we then should do is we should be casting a net around all of this. For us as investigators, navigators, advocates, outreach, and for the patients. And in doing so, we should be forming sustained partnerships. And that's part of the reason why anytime Tom Farrington or Dr. Keith Crawford calls me up to say, can you come and talk? I will do it because there's value for us to be together for patients. For investigators in pharma, we have to improve upon trial design. And for regulators should be requiring diversity and inclusion in clinical trials. And once we have all that stuff put together, let's open trials where the patients are. So we have a lot of things that we can do together. This is just a brief overview of my thoughts here. And I would just say these are my key takeaway points. Clinical trials are a part of cancer care. They're an opportunity to get care. And that Black patients can do just as well and maybe even better. So we need more Black patient participation. I would say the same thing about Latino patients, as well as Asian patients and Native Americans as well. And we can do a better job across the entire patient care continuum by putting the patient at the center. I want to thank you for your attention. I want to thank Dr. Crawford, Mr. Farrington for this opportunity to come and speak with you. I'd be happy to take your questions either now or even in the future by email. Thank you.
Rick, that was extremely informative. And it's exciting about it because this is the first time that I'm aware of where this type of information was brought together, not only for the patient to understand, but we also have our pharma partners who are on the line also. And I noticed that there's certain areas that you brought out that the investigators needs to work on, or they have opportunities to work on. And these are things that you will hear from our partners who are already working on it, but a lot of people don't know. So there's a couple of questions.